Pathology 1422. You're welcome. I'll be taking you on the complications in blood transfusion. You can remember you did the blood transfusion. You did the blood transfusion third year. So we are going to look at some of the complications that are associated with blood transfusion. All right. So our outline includes transfusion complications, non-infectious transfusion complications, reactions to red blood cell antigens. Under that, we have acute hemolytic transfusion reactions. We have delayed hemolytic transfusion reaction. We have reaction to donor proteins, minor allergic reactions, anaphylactic reactions, white cell-related transfusion reactions, such as febrile reactions, transfusion-related acute lung injury. Then we have infectious transfusion-transmitted diseases. We have some that are virus, some are bacteria. Then we have investigation of blood transfusion reaction, quality regulation, relevant legislation, ethical issues in connection with blood transfusion reactions, and also alternatives to blood transfusion reaction. These are the things I'm expected to cover with you. Remember, you have other lecturers too that have their sections under this 422. So at the end of this lecture, we will note that blood transfusion still causes some degree of complications, some degree of harm. So it's not a total 100% safe process or treatment option. So it's not 100% safe to give blood. So that's why we are looking at some of the harm that blood transfusion can still cause. You should also be able to recognize blood transfusion reactions, understand the complications or reactions to blood transfusion, give detailed explanation, both clinical and laboratory, for each of the transfusion complications, and then be able to carry out laboratory investigation for the identification and classification of a blood transfusion reaction. These are the things you're expected to know. So what is the scope of this problem? So each fiscal year, the FDA produces data on complications or prevalence of complications of blood transfusion reactions. This slide now shows the prevalence of some transfusion complications as at 2022 fiscal year. Okay, so you can see when you look at by your right, you see some of the, when you look by your right, you see some of the complications, transfusion complications we have, which we are still going to take one by one in the course of the lecture. You can see citrally, TACO, HTR due to non-ABO contamination, anaphylaxis, transfusion reaction, not type, not determined, and others. So when you look at these reports for the prevalence of these transfusion reactions as at 2022, you find out that trially, one of the transfusion complications, is still persisting. TACO is still persisting. I said we'll look at them one by one so you understand their pathophysiology. Then you find out that it's a very good news that when we look at hemolytic transfusion reaction due to ABO, okay, when you look at 2022 fiscal year for reports on complications of blood transfusion, find out that this transfusion reaction due to ABO has completely been handled. Okay, so you can see it in 2021, 2020, 2019, 2018. But as at 2022, you find out that complications arising from reactions due to incompatibility in ABO blood group have been seriously dealt with and almost eliminated. So we pray it does not appear again during the next report by the FDA. So you can find others are still there. Hemolytic transfusion reactions, some are not due to ABO, they are still there. Contamination is still causing complication in blood transfusion. Anaphylaxis, okay? So that is what this slide is showing. The scope of the problem still tells us that we still have some fatalities. We have some problems, complications in giving blood. Blood is not 100% safe. Okay. So also this slide, okay, transfusion associated fatalities by complications. Okay, when you look at the number of complications broken down into numbers, anaphylaxis as at here 2, then it increased and then decreased again and then remained steady as at this time. So for this fiscal year 2022, the highest cause of complications in blood transfusion is TACO, 44%, okay, followed by HTR of non-ABO. ABO HTR is almost zero, just like the graph showed us. Okay, so the highest cause of complications due to transfusion, as we can see, as at 2022 fiscal year, is TACO, followed by HTR due to non-ABO blood group, and then anaphylaxis. Okay. So this data goes to prove to us that blood transfusion is not 100% safe procedure. That in as much as we use it to treat someone of a disease condition, the person may end up acquiring another complication which may cause the person fatality or harm. So you need to know that at the background of your mind. So classification and subtypes of transfusion reactions. We have there are various forms, there are various ways we can actually classify transfusion reaction, but here we try to classify transfusion reaction based on the time of onset. So we used acute or delayed. So under acute transfusion reaction, we have all these complications. For example, febrile non-hemolytic transfusion reaction, acute hemolytic transfusion reaction, septic reactions due to bacterial contamination. Okay, that is transfusion-related sepsis, transfusion-related acute lung injury, minor allergic reactions, anaphylactic reactions, transfusion-associated circulatory overload. Okay, hypotensive reaction, transfusion-associated dyspnea. Under delayed, we have delayed hemolytic transfusion reaction. We have transfusion-associated graft versus host disease. We have post-transfusion purpura. We have transfusion-associated graft versus host disease. I've said that. Okay. So alloimmunization, transfusion-transmitted infections. We have immunomodulation. Okay. So we are going to take them one on one. We are going to handle acute transfusion reactions first. And you should know the reactions we have under that group of complications. So by definition, acute transfusion reaction presents within 24 hours of transfusion, and they vary in severity from mild febrile or allergic reaction to life-threatening events. So these are complications due to transfusion reaction. Their time of onset is less than 24 hours of transfusion. You can see the person manifesting some clinical presentations that will help you to actually know that this individual is having an effect due to the product that was given to him or her. So under, just like we said in the table earlier, that under the acute transfusion reactions, these transfusion reactions that set in within 24 hours of blood transfusion, we have acute hemolytic transfusion reaction that are due to ABO incompatibility. We have febrile non-hemolytic transfusion reaction. We have bacterial contamination of blood can give rise to this type of reaction. We have transfusion-related acute lung injury. We have allergic transfusion reaction. We have transfusion-associated circulatory overload. Okay, so we're going to look at looking at acute transfusion reaction generally. So we've defined them and we've listed the complications that are under the acute transfusion reactions. So what are the signs and symptoms of these acute transfusion reactions in general? So we have fever. You can see in this table, we have fever, we have urticaria, we have angioedema, and we can find fever in febrile non-hemolytic transfusion reaction. These are acronyms, short forms for some of these complications, okay, or septic reaction. So these are the specific acute hemolytic transfusion, acute transfusion reaction where we can find fever, okay. So we can find urticaria in allergic transfusion reaction or anaphylaxis, angioedema, okay. So also dyspnea or hypoxia, we can see it in taco severe allergic transfusion reaction. Bronchospasm, we can find in allergic transfusion reactions or taco. Pulmonary edema, these are the signs and symptoms of acute transfusion reactions, and the specific acute transfusion reaction where we can see them. Okay. As it continues here, we also have pain as a symptom. We have severe anxiety, okay, acute onset of bleeding. Okay, DIC can be associated with acute hemolytic transfusion reaction or septic reaction. We will take these transfusion reactions one by one for more details. So under acute transfusion reactions, as you see in the table we showed earlier, we have acute hemolytic transfusion reaction. So what is acute hemolytic transfusion reactions? We say that acute transfusion reactions generally are reactions that sets in less than 24 hours of blood transfusion. Okay, so acute hemolytic transfusion reaction is a potentially catastrophic destruction of incompatible red blood cells. The incidence is 1 in 76. Transfusion, okay, is mainly due to clerical errors, okay, labeling a donor wrongly or labeling a patient wrongly, or problem in identifying the blood group of the patient, or problems with identifying the blood group of the donor, which makes transfusion to be ABO incompatible. Red blood cell destruction may be intravesicular or extravesicular. It normally leads to red blood cell destruction, as you can see from the title, from the name, acute hemolytic. It is acute and it is hemolytic. That's red blood cell destruction. Okay, some are ABO related, and when they are ABO related, intravesicular, usually more severe. Okay, the reaction are usually more severe when the blood transfusion, there is incompatibility in the ABO blood group, carrying a donor that is maybe as a result of improper blood grouping. You identified someone as blood group O, probably because you are using reagents that have expired. That is how we can also encounter such problem. Some may use reagents like antisera that have expired, that are no more active, and try to group a donor. Probably the donor or the patient may be blood group A and they said it's O because the reagents they are using have expired. Sometimes you can even go to market and buy kits that have expired and they change the date. So when you are trying to do blood group for some persons, make sure that's why we always add control. This is an established blood group A. In the test panel you are setting up, you already have controls. This is an already established blood group A, and you are now trying to group an unknown person, either donor or the patient. So you add that to your control cells. When you now use the reagents that you bought, and even the control is giving you, you know definitely that this reagent is not working. Okay, so at each point you are performing any laboratory investigation, you need to add control. Don't look at it that blood grouping is a simple thing to do. Sometimes you will go to market, we buy these kits. We also relates to the storage of the kits. These kits they are selling are supposed to be left at 4 degrees centigrade, but you find them keeping it at the shelf. Okay, some of these things may affect the lifespan of the antisera we are buying. And when we buy it and come to do tests with it, sometimes you obtain false results. So as a scientist, you should know the value of adding control in anything you do, because that may be one of the reasons that these complications can come up, and it's very, very disastrous when somebody that is blood group B, you end up giving the person blood group A because you grouped it and it gave you O because you are using an expired reagent, antisera. So some of them are caused because of ABO related problems, and then some of them are non-ABO related problems. So this diagram is trying to show us the level of the complications. You can see acute hemolytic reaction. Almost all the organs in the body are affected. There is no organ in the body that is not affected. The heart, the kidney, the liver, everywhere is affected. Okay. So some antibodies that have been identified to cause this type of reactions, according to the FDA, these are some of the antibodies that were implicated in the cause of this acute hemolytic transfusion reactions. Okay, as at 2022, there are 6. Okay, so you have ABO, multiple antibodies, have others, have D, have E. So these are some of the antibodies that have been implicated in causing acute hemolytic transfusion reaction. Okay. So you can see that the fatalities due to acute hemolytic transfusion reaction has been decreasing. Okay, has been decreasing as the year goes by. So what are the signs and symptoms of this acute hemolytic transfusion reaction? We have fever and chills is the most common presenting symptoms. You see the person serious rigor, maybe shaking even on the bed. The patient may have back or infusion site pain, hypotension, and then shock. Okay, hemoglobinuria may be the first indicator of hemolysis in patients that are under anesthesia, because you may not see some reaction, but you find out that person is passing blood in the urine. Okay, so DIC, increased bleeding, also important in patients that are under anesthesia. And then psychological instability. That is why within the first 30 minutes of initiating blood transfusion, the clinicians always hang around. Okay. what you see in the clinic. Okay. In the laboratory, we find hemoglobinemia. You can see in this test tube at the top right of the screen. Okay. When we get the blood of the transfused patients and allow it to settle in an EDTA bottle, okay, you can see due to the destruction of red blood cell, you can see the first tube represents the normal way the serum should look like, clear without any red coloration. But due to the lysis, breakdown of red cell that is going on inside the patient, if you leave the red cell to settle inside an EDTA tube, you find some levels of discoloration depending on the intensity or depending on the extent of the destruction of the red blood cell. That's what we mean by hemoglobinemia. Last several hours in those with adequate renal function. Okay. Then hemoglobinuria typically clears by the end of one day. We can find also positive direct antiglobulin tests. Okay, unless if there are no cells again to do the DAT, the direct antiglobulin test, unless if all the donor cells have been destroyed. But if not, we expect to find a positive DAT. Okay, maybe a mixed field, but we expect to find that. We have elevated direct and indirect bilirubin. You can find that from the breakdown of the hemoglobin. Laboratory finding of DIC. Okay, to confirm that DIC is taking place, if we estimate the D dimer of the patient, we find out that it's on the increase, the decreased fibrinogen, etc. That is to monitor DIC. Red blood cell abnormalities, we say schistocytes, intravenous hemolysis. If intravascular hemolysis is occurring, we have more of schistocytes, the helmet red cells. But if the hemolysis is extravascular, we have more of spherocytes. The red cell looks more like spherocytes. Okay. So what is the pathophysiology of this acute hemolytic transfusion reaction? One, what triggers the reaction does not take much blood for this type of reaction to be initiated. Just as little as 10 ml of blood that will enter the patient from the donor blood bag can actually initiate this reaction. Okay. Intravascular hemolysis due to ABO incompatibility typifies these reactions. Okay. ABO, you know that ABO antibodies can fix complement very well. Okay. So, and this leads to membrane attack, complex and rapid red blood cell lysis. Okay. Other antibodies, the kid may also fix complement and rise red blood cell. That is why they are also implicated in this acute hemolytic transfusion reaction. Seen much less commonly with incompatible donor plasma. Okay. So, because the ABO antibodies, which are involved in the transfusion, can fix complement and initiate membrane destruction, okay, that is why ABO incompatibility can cause hemolysis if the wrong group is given to the wrong person. Okay. So transfusion happens, agglutination, complement fixing, and then hemolysis. That is the stage of the complications due to ABO incompatibility or other blood groups that can cause acute hemolytic transfusion reactions. Hemolysis leads to a complex array of events, including the release of free hemoglobin and hemoglobin-free red blood cells stroma into circulation. So this hemolysis or destruction of the red blood cell leads to so many catastrophic, harmful events. The hemoglobins are released, even the free hemoglobin red blood cell stroma also are released into are in the circulation, and they can destroy the kidneys. Okay, also the stimulation of the intrinsic coagulation pathway and bradykinin via antigen antibody complexes. Okay, C3A and C5A generates anaphylatoxins, production of several very important cytokines, tumor necrosis factor, interleukin 1, interleukin 6, interleukin 8. So all these are as a result of transfusing the wrong blood group to someone, not matching somebody's blood group to the appropriate blood group. So it's a very serious catastrophic event which should be avoided by all means. So some of the substances, just like in the last slide, some of the substances generated during acute hemolytic transfusion reaction and their effects. Okay, so this complement 3A, complement 5A, they increase the nitric oxide, cytokines, and histamine. These are their effects. Tumor necrosis factor increases NO, tissue factor expression, decreases thrombomodulin, and all these, their effects have their consequence on the body. Interleukin 1 increases NO, decreases thrombomodulin. Free hemoglobin scavenges NO, okay. Bradykinin transient hypotension, okay. Red blood cells from stroma, direct renal tubular damage, okay. The net effect on various systems, inflammatory consequences. The TNFA and all these cytokines strongly promote fever, pyrogenic, that is, they are pyrogenic. WBCs activated and stimulated by all of the above, as well as interleukin 8. Okay, you have inflammatory consequences, have coagulation consequences. We've said that it triggers the coagulation pathway due to the antigen antibody complex. Okay. Also the circulatory consequences, okay. The circulatory consequences can lead to systemic vasodilation, okay. The bradykinin generated from the antigen antibody complexes likewise promote transient systemic hypotension, okay. On the other hand, the massive free hemoglobin released may reduce local NO, leading to at least localized vasoconstrictions. You know, the NO causes vasodilation, okay. So renal consequences due to the hemoglobin red blood cell stroma can actually reduce renal function, renal flow. So respiratory consequences leads to the anaphylatoxins that are released promote bronchoconstrictions from histamine release with resultant wheezing and dyspnea. Okay, aggressive hydration during resuscitation gives pulmonary edema risk. Extravascular hemolysis can result as a result of incompatibility in some of these other and in some of these blood groups. It's usually less severe due to lack of systemic complement and cytokine activation. So how can we prevent this? By training and careful attention to phlebotomy, labeling, and administration. Some require 2 separate ABO resource types before transfusion. Advanced method using barcode, and also the example I've given us as far as our environment is seriously concerned, apart from these preventive points that are listed here, will take into recognition that sometimes we may get antisera that are expired or that were improperly stored and have lost potency. And how can we mitigate that? By making sure that each step of this blood grouping, we involved already known control, both positive and negative, to check whether our kits are working. Thank you. Okay, so I think I will end here. Okay, if you have any questions,